Good evening, good afternoon in some places, and welcome to our webinar entitled Warning Signs and What to Look For, Anxiety and Depression in Childhood with Dr. Joan Luby. I'm Dr. Jeff Borenstein. I have the privilege of serving as the president and CEO of the Brain and Behavior Research Foundation. The foundation is the largest private funder of mental health research grants. I want to jump right in to our presentation, our conversation tonight, which really is geared towards teachers, school counselors, other educational professionals, as well as parents, people who are on the first line of helping children, adolescents who may be in need of help. Today, we are very fortunate to have Dr. Joan Luby. Dr. Luby is the Samuel and May S. Ludwig Professor of Child Psychiatry and Director and Founder of the Early Emotional Development Program at Washington University School of Medicine in St. Louis. Dr. Luby is a member of the BBRF Scientific Council. She's received a number of grants, including a Young Investigator grant in 1999 and other recognition from BBRF. And I want to just say thank you for joining us today, Joan, and let's jump right into it. And I want to start with, I think, a very important question, which is, what age, how early can symptoms of anxiety and or depression start in a child?
Well, that is a really important question that we've been interested in. I mean, I think we don't really know how early it can begin, but as far as what the empirical data is available, we know that we can identify depression as early as 3 years of age. And you may be able to identify some anxiety disorders even before that. But having said that, most people really have not explored how anxiety and depression might manifest, and importantly, how it might be distinguished from developmental norms even earlier in childhood. But I think by the age of 3 is when clinicians can start looking for it, and we can provide guidance on the signs and symptoms.
So what does that look like at such a young age? And then what does it look like as the child may get older?
Mm-hmm. So just to provide a little bit of history and context here, I mean, one of the interesting things is that there was sort of a resistance in the field for a very long time to accept the idea that children could be depressed. It really wasn't until the 1980s when empirical studies came out showing that children could be depressed and that depressed children had the same fundamental symptoms of depression as depressed adults. Previously, people said either children were developmentally too immature to experience the core affects of depression, or they said they would experience sort of mass symptoms of depression like stomach aches or aggressive behavior. And then the research started to show that no, that was not the case, that children, in fact, were a lot more emotionally sophisticated than we had previously understood. And they provided, Carlson and Cantwell, in a landmark paper called Unmasking Mass Depression, provided data showing that depression in children looks just like it does in adults. In other words, they have anhedonia, which is decreased ability to enjoy activities and play. They have sustained sad mood. They have inability to sustain joyful moods. They have disturbances in sleep and appetite. We essentially sort of capitalized on that work and then asked the question of what would this look like even younger than age 6, and discovered that we could find it in children as young as age 3 with kind of developmentally translated probes about the symptoms. So that is, anhedonia might be inability to enjoy activities and play. Obviously, it's not something like decreased libido like we see in a 25-year-old. The other issue is that young children are inherently so joyful that sometimes it's more evident by declines in joyful behavior. So those are other markers that are very important to attend to.
And how about in a slightly older child? What do we see in an elementary school age child that may be experiencing depression or anxiety?
Yeah, that's where you're going to see sort of some social withdrawal. Certainly with anxiety, you're going to you will generally see a lot of social withdrawal. You see children sort of showing more sadness, decreased motivation to engage in joyful activities, to engage in social activities. You might see changes in appetite. You might see sort of psychomotor slowing and fatigue. But the reason why these symptoms are so often missed, and they are often missed, is because caregivers and teachers tend to pay more attention to disruptive behaviors, obviously, because those behaviors are disruptive. They disrupt classrooms, they disrupt family activities, and depressed kids tend to not, they sort of fade into the background, and for that reason are often less identified by teachers, but perhaps more parents may be more sensitive to those symptoms.
So what type of things should a teacher look for along those lines? Are they looking for a change in behavior where somebody who might have been a little bit more outgoing, more interactive in the classroom, less so? What should a teacher be looking at in individual children?
Yeah. So in terms of depression, a teacher probably would be looking for change in behavior unless they're meeting a child when they're already depressed. I mean, sometimes you can have children who have more of a chronic sort of dysthymic condition. Therefore, you wouldn't necessarily see a change. But yeah, I think you would see more withdrawal, more sadness. Another thing that is actually a very important sign is increased guilt. So young children who are depressed actually experience high rates of guilt. They feel guilty for things that aren't their fault. When they commit a transgression, they do something wrong, they're much hard. It's much harder to reassure them or for them to shake it. So those types of behaviors are also things teachers should look for, as well as inability to enjoy joyful activities, lack of sort of motivation to engage in social relationships, and also just negative self-talk, feeling that they're bad, feeling that they're not smart, not feeling happy with themselves, being very negative about themselves.
So when a teacher sees this, or when parents see this, or when a teacher sees this, what should they do? What's the next step to help the child?
Well, ideally, the next step would be referral to a mental health clinician. And let me also say that, those symptoms should be not necessarily persistent, but they should be sustained over a couple of week period. So, I mean, obviously, any child can be sad one day or have a loss and be very irritable, which irritability is also another sign, but it's a very nonspecific sign, which is why I didn't mention it. But a child who we're worried has a clinical depression has these symptoms in a persistent way. They will brighten at times, so they don't have to be like vegetatively depressed, because young children are just inherently happier, but they would have sadness for large parts of the day, more than usual, for more days than not in a week, for a couple of weeks. And when that's observed, then it would be time for a referral to a mental health clinician.
And how common is this? What percentage of kids do we have a sense may experience these kind of symptoms?
Well, for depression, we know it's got about a 2% prevalence rate prior to adolescence. At adolescence is when the prevalence rate of the disorders go up sharply. And some data suggests, particularly in girls, then it will go up to like 8 to 10%. But prior to adolescence, and down to age 3, prevalence rates are about 2%. Of course, we do see it's something that runs in families, as we know. So when there's a family history of depression, we would be more suspicious of it. And those children would be at somewhat higher risk.
And as you mentioned adolescents and the percentages there, what are the symptoms for teenagers, for adolescents and a little, as they go through the teenage years, middle school, high school? What type of symptoms should we be looking for during that period?
Yeah, the symptoms, again, are very similar. There's a lot of continuity of these symptoms of depression across the lifespan. That is increased sadness, increased guilt, anhedonia, changes in sleep and appetite. When you get into adolescence, that's when you also might see more passive suicidality, maybe active suicidality. I mean, suicidality can, of course, occur outside of a mood disorder, outside of depression. But as we know, there's an increasing prevalence of suicidality currently. And that is sort of an important marker that often becomes clear in adolescence. So self-harm and self-harming behavior might be another sign, although that can be a non-specific sign as well.
But obviously a very important one to take action on. If a child is having thoughts of hurting themselves, is acting on that, these are issues that need to be addressed right away. This shouldn't be.
Absolutely. Absolutely. And let me also say that another thing that I think we're starting to understand is that suicidality is being observed and occurring much earlier in childhood than we previously understood. So we've seen suicidality at sort of surprisingly high rates in depressed preschoolers as early as 4 and 5. We've done studies looking at whether these children understand the permanence of death and found that those who have suicidal ideation understand the permanence of death even more than those kids who don't. So expressions of suicidal ideation, either passive or active, can arise even early in childhood and should be taken seriously. That doesn't mean we should panic or take kids to the emergency room, but it means we should take it seriously and address it.
Right. I think that's a very important point, given the rates of suicide and the increasing rates of suicide. And for the adolescent age group, it, I believe, is the second leading cause of death amongst kids that age. So it's very important. I'd like to shift gears a little bit. What's the treatment? What happens when somebody goes for an evaluation? What do they do? What does that entail? And what's the treatment?
Yeah, no, that's a really important question. So when we're talking about kids older than 6, we know there are several forms of psychotherapy, like cognitive behavioral therapy, that are proven to be effective. There are some sort of age-adapted forms of interpersonal psychotherapy that have been tested in pre-adolescent kids as well. Of course, there are an array of medications that have been tested for children as young as age 6 or 7, which are also proven to be effective. So when you talk about kids 6, 7, and older, there's a number of treatment options. And, many of these treatment options are quite effective, even though, of course, we are still searching for more effective treatment options. When you look at kids under the age of 6, that's where you get into the zone where there are the intervention literature and the interventions are much more sparse. First of all, the use of medications for depression in children under age 6 is not recommended because there really is no data looking at the safety or efficacy of those medications in children under 6 at this point in time. There is at least one form of psychotherapy that we have worked on developing and testing at Washington University called parent-child interaction therapy emotion development, which is a manualized form of therapy that was tested in a large-scale randomized controlled trial. It targets the parent-child relationship and it targets the child's sort of emotional competence, and that's proven to be very effective. The problem is I it's really not widely available at this point in time. Even though the manual to do it can easily be downloaded, and there are a number of therapists in early childhood who know these approaches, but it's those types of therapies that need to become much more readily available across the country at this point, and that's where we run into a roadblock.
I want you to explain a little bit about the importance of early identification of these symptoms, why that makes a difference for the child.
Yeah, no, that's early identification is so important. And the reason why that is the case is because, generally speaking, when you look at sort of cognitive, social, and emotional skills across development, and these are all of the components that are involved in depressive disorders. That's where we see impairments in those domains. They're much more changeable earlier in development, because earlier in development, we generally know that the brain is much more neuroplastic. That is, it will change in response to environmental and psychosocial experiences. So that's one of the reasons why we think that early identification of psychiatric disorders, and particularly mood and anxiety disorders, is so important, because we believe there's a window of opportunity earlier in development to more effectively treat. Now, this still needs to be studied. It still needs to be more rigorously tested, but there's a lot of evidence in general that this is the case. For example, if you look at a disorder like autism, we know that when you treat that disorder earlier, you have much better outcomes as opposed to when you treat it later, partially because these are chronic disorders. So one issue is that when a child continues to experience episodes, that has developmental effects that are negative. It has negative effects on the brain when the child's in an episode of depression for a longer period of time. And because of this neuroplasticity and the ability to change earlier in development, that's the fundamental reason why early identification is so important.
And just to emphasize that the brains are still developing at that younger age, and even among teenagers and in the early 20s, the brain is still developing. So the good news is that treatment can have an even greater impact on those developing brains. So extremely
Exactly. And many people believe that adolescence is another period of very high neuroplasticity, which is another reason why that's a real focus of attention.
One of the concerns in adolescence, among all adolescents, is the issue of substance misuse, experimenting with drugs, misusing drugs. And I'm curious about the interplay between anxiety and depression and the risk of then experimenting with and misusing drugs and alcohol.
Yeah, I mean, I think that's a huge risk. And I think that a lot of adolescents, one of the problems that we have with sort of the stigma associated with mental disorders is that children and their families don't necessarily identify, label, focus, and go for treatment. And therefore, it leaves these conditions untreated, but still very, very distressing and impairing. And that's, in some cases, the reason why many adolescents do turn to substance abuse, because it's a way of managing the symptoms. But of course, it is a very maladaptive way of managing the symptoms that will ultimately exacerbate the symptoms. But I do think that one fundamental issue there does have to do with the stigma. If a child had a pneumonia, they wouldn't be sort of afraid to go to the doctor and say, I need some medications, and try to treat it themselves at home, at least generally speaking. And I think that's kind of the problem that we have with mental disorders. Even though it's gotten better, that's still a problem.
It's a very good point. And along those lines, if a child was walking with a limp because they injured their leg, I think it's more straightforward for the teacher to say to the parent, your child's walking with a limp, have that checked out.
Yeah.
What advice do you give to teachers? Because it can be a little bit more of a difficult issue for the teacher to then bring this up with the parent. How do they best approach that with the parent?
You're right. That is very tricky. I mean, I do think that it's important for teachers to let parents know when they see concerning signs, just across the board. Now, they may run into parents who are not going to be very receptive to hearing that, who might be defensive about it, who might want to write it off. I still think it's important for teachers to let parents know. Sometimes these are things that you tell a parent, and even though they might not initially or immediately embrace it or consider it or take it seriously, sometimes it will, you're planting a seed. It's a process. It may take some time for the parent to accept that this is something that they need to grapple with. And if the teacher last year told them, and then the second grade teacher tells them, that reinforces it. So I would encourage teachers to not hesitate to notify parents about these concerns. I mean, how much teachers can do the work of really sort of educating parents on the existence of mental disorders, their reality, their validity, why they come about, the fact that they can be treated. That may be beyond the scope of what a teacher can do. But that's, of course, where school systems might come in and sort of emphasize those types of things a little bit more in terms of general programming.
Right. And even if the teacher, as you said, puts the foundation for the parents to see it. And sometimes the parents know their kids better than anybody. This may help them see it because they may have sort of noticed it on their own, and having the professional say something could be helpful. One idea would be to even say to the parent, you may want to discuss this with the child's pediatrician and get some further feedback and see what, if anything, needs to be done about it by getting further professional help along these lines.
Exactly. I agree. I mean, I've had so many patients come to my clinic where the parent may say the teacher thinks there's something wrong. I don't see it, or I don't really agree, but the teacher thinks so. So, I mean, I think parents do take what teachers say quite seriously, and then they do go seek professional help. And sometimes that leads to a much greater understanding on the part of the parent, ultimately.
When the child begins treatment, how long does it take to start to see results? What is that process like?
So, depending on the type of treatment, again, so in the treatment that we use for the kids under age 6, we had an 18-week treatment that was a psychotherapy that was delivered by a master's level clinician. And we saw very positive results after this 18-week period. We saw kids starting to get better even after the first few weeks of treatment, which is part of the reason why I think parents remain so engaged. Now, again, that's early childhood where we have the plasticity. When you get into older kids, sometimes the process might be slower. Of course, as you know, with the use of medications, that can take, 2 to 3 weeks to begin to see effects. So you do have to be patient with it. It's not something that's going to be a quick fix. It's sort of a process. The other problem is that a child who's depressed, of course, is vulnerable to another episode, even if they are effectively treated. So in many ways, it's kind of something you need to be attentive to over the course of development. And you might need course corrections. You might need boosters. It's something to sort of keep your eye on in a lifelong way for many people.
But a key point, I agree with you, keep the eye on it. But a key point is that with treatment, the children get better. That
Yes.
These are fully treatable conditions, may need tweaking at some points, but the children get better. They could function at a high, full level with that appropriate treatment.
Absolutely. And the other reason why it's so important to treat it in childhood is because during childhood, children are traversing a steep developmental curve. They have a lot of things to do developmentally. There's high levels of sort of social challenge, social emotional development, cognitive challenge, motor development. And if a child has an anxiety disorder or a depressive disorder, that doesn't just impair them in their daily life and increase their distress, which is a problem in and of itself. It also sort of drags down their development, which then can become a vicious cycle. So that's another reason why it's very important not to ignore these conditions in childhood.
So in addition to potentially affecting them academically, it could certainly affect them socially due to anxiety or depression, not socializing with their peers in a way that is healthy developmentally, as well as other issues. So you want to jump in there and intervene right away and keep them on the right path.
Exactly.
As we come to the conclusion of our conversation, I want to ask you, you're speaking to a good number of teachers, other educators, to parents. What do you say to them? What's your guidance to them if you were looking at them who's watching right now? What do you say?
I think what I would say is that children are very vibrant emotionally, even early in development. They're much more aware. They have much deeper feelings. They have a much broader range of emotions. They're very capable of complex emotions. They feel intense guilt. They can, so that these are things that are very important to pay attention to. Just as much as you're paying attention to their motor skills, to their language skills, children are really burgeoning in this domain. And it's really, really important for us as educators, as caregivers, to foster and facilitate this. And this is the reason why we have to think about emotional functioning, identify disorders as soon as they possibly arise, and work to treat them.
Joan, thank you so much for the clinical work that you do, for the research that you've conducted and will continue to conduct, for joining us today, sharing this extremely important information. I really appreciate you doing this with us today.
Thank you so much for having me. I really enjoyed it.
And to our audience, thank you for joining us. This is being recorded, so if you want to refer to a friend or a colleague, it could be seen on our website. We're also going to be sending an email to everybody who had registered with the opportunity, if you do have questions, to submit questions back to us. And we will try to answer as many of those questions as possible on our website. So we'll have this information available for people because this is so important for educators, parents, the general public, for all of us to be aware of. So with that, I'm going to say again, Joan, thank you so much. And everybody in our audience, thank you. And I wish everybody a pleasant evening and rest of the day. Take care, everybody.